everyone, this video discusses clinical governance and its role in the medical laboratory. So firstly, what is clinical governance? Clinical governance ensures healthcare professionals are held accountable for the quality, safety and satisfaction of patients in the care in which they deliver. Clinical governance was implemented in 1998, ensuring and highlighting the duties, responsibilities, authority and accountability of healthcare professionals in providing a high-quality service for the patient at all times. The introduction of clinical governance provides total quality assurance within the healthcare environment. It promotes and ensures improved patient experiences and better health outcomes in terms of quality and safety. But what is the role of clinical governance in the medical laboratory? It maintains a high quality service with the patient's best interests in mind at all times. It ensures constant improvements of services they provide, like quicker turnaround times and high levels of precision and accuracy. Clinical governance strives to achieve excellence in regards to health and safety in the medical laboratory. It does this by safeguarding and promoting high standards of care. This allows for minimal risk and better overall patient outcomes. Clinical governance encourages an improved staff experience by ensuring every member of the profession is working to the same standards, providing results of the same quality. Continuous professional development will allow the service to evolve and improve in future years. The pillars of clinical governance are discussed later on in this video. However, the main guiding principles it uses are patient first, patient safety, personal responsibility, and clear accountability. In order to meet accreditation standards, the laboratory must participate in an EQA scheme. This allows for inter-laboratory comparison, ensuring results obtained are meeting expected targets and providing the patient with a clear and accurate result. IQC ensures the provision of accurate and precise results. Quality assurance and its strict implementation guarantees the right result from the right test at the right time from the right specimen from the right patient. QA governs a controlled process, starting with taking a patient sample right through the reporting of results to the appropriate clinician. Clinical governance ensures that all steps and tasks are logged and documented for traceability purposes. INAB are the accreditation body in place for medical laboratories in Ireland. INAB assess and recognise the processes in place within the laboratories to achieve the best patient care possible. To become accredited, the laboratory must be in compliance with the ISO 15189 standards, showing all staff are trained accordingly, instruments are validated, processes are controlled, etc. For us, clinical governance mostly involves the contribution of our service to the care of the patient. However, it's so much more than that. In 2008, blood transfusion laboratories adopted the ISO 15189 standards due to mandatory accreditation requirements. Breaches in patient care and safety prompted this. Blood transfusion labs must also comply with the additional requirements relating to blood traceability and haemovigilance.
There are 10 guiding principles of clinical governance. The first principle is patient safety. This is based on a partnership of care between patients, families, carers, and us healthcare providers in achieving safe, easily accessible, timely, and high-quality service across the continuum of care. 2 is safety. Identification and control of risks to achieve effective, efficient, and positive outcomes for both patients and staff. 3 is personal responsibility, where individuals, whether they are members of healthcare teams, patients, or members of the public, take personal responsibility for their own and others' health needs, where each employee has a current job description setting out the purpose, responsibilities, accountabilities, and standards required in their role. 4 is defined authority, the scope given to staff at each level of the organisation to carry out their responsibilities. That individual's authority to act, the resources available, and the boundaries of the role are confirmed by their direct line manager. 5 is a clear accountability, a system where individuals, functions, and committees agree accountability to a single individual. 6 is leadership, motivating people towards a common goal and driving sustainable change to ensure safe, high-quality delivery of clinical and social care. 7 is interdisciplinary working. This working focuses on the interdependence between individuals and groups in delivering services. This requires proactive collaboration between all members involved. Next is supporting performance. This is done by supporting a director or line manager in managing the service and employees, thereby contributing to the capability and capacity of the individual and organisation. Next is open culture, a culture of trust, openness, respect, and caring where achievements are recognised. Open discussion of adverse events are embedded in everyday practice and communicated openly to patients. Staff willingly report adverse events and errors, so there can be a focus on learning, research, improvement, and appropriate action taken where there have been failings in the delivery of care. Lastly is continuous quality improvement. This is based on a learning environment and system that seeks to improve the provision of services. Once expectations and the means to measure them have been established, implementation aims at preventing future failures and involves the setting of goals, education, and the measurement. Cases which highlight the importance of clinical governance. First up is the case of Nora Hyland. On February 13, 2012, Nora Hyland gave birth to a son via C-section. However, 3 hours later, she died in theatre after suffering from postpartum hemorrhage. Nora waited 40 minutes for a transfusion. However, due to a small mislabeling error in the blood transfusion lab, there was a delay in the blood reaching the theatre. In this case, there was a no emergency blood fridge in the theatre that was stocked with O-negs. And as a result, an emergency O-neg fridge was put in place. Next is the cervical screening controversy. In Ireland, all smears are reviewed twice by trained medical scientists. All abnormal smears are reviewed by a third cytologist. 30 to 50 smears are reviewed by each cytologist per day. Irish cytologists follow the British Society for Clinical Cytology guidelines on workload, auditing, training and quality assurance. The first smears were outsourced to Quest Diagnostics in the US in 2007. It was discovered that the rate of high-grade smears being reported was 1.2%, compared with the 1.9% expected result. Concerns with outsourcing to the US included high throughput of smears with each cytologist, manually screening up to 100 smear tests per day, which may be linked to a significant reduction in sensitivity. US laboratories follow different guidelines. They follow clinical laboratory improvement amendments. New workload recommendations have since been made. It was also concerned that not all smears were reviewed twice, as this was not common practice for their smear analysis procedure. Vicky Phelan's smear in 2011 was reported as showing no abnormalities. An audit which took place in 2014 showed that her 2011 smear was inaccurate. She was diagnosed with cervical cancer in 2014. Ms. Phelan was not informed of the audit findings until later in 2017. In Vicky Phelan's case, there was no clear accountability, there was clear non-disclosure, and open disclosure was implemented in 2010, and there was also weak governance of the audit. Following on from this, recommendations were made. The open disclosure policy was revised, more consideration was given to women's health. Patients were allowed access easier and more promptly to their own medical records, and patient advocates sit on HSE boards.
Created using Powtoon.